So today I would like to talk to you about our clinical experience in using surface-guided clearance mapping, in particular using essentially MapRT for non-coplanar treatment planning. So I will try to convince you a little bit why we need non-coplanar treatments, and then a little bit of devil's advocate why not non-coplanar treatments, and then I'll walk you through a couple of use cases. In this case, we have long SGRT and also stereotactic partial breast irradiation. So first of all, the goal of radiation therapy planning, to summarize in one sentence, is pretty simple. Essentially, you want to respect target coverage while at the same time reducing the OAR doses. This is especially important in stereotactic treatment planning because we're giving most often a very high fractional dose, and we want to make sure the surrounding OARs are doing fine. So the evolution of treatment techniques, should I stay here to keep the volume? Yeah, the evolution of treatment techniques essentially is to enable this goal by expanding from 3D to IMRT to VMAT. We are essentially gaining more degrees of freedom in how we can manipulate the beam and gaining more capability for dose shaping. And then, in this case, the expansion from coplanar to non-coplanar follows the same realm. We are gaining literally more angles to play with when we do planning. So there are a lot of literature out there. I'm not going to make you guys sit here and read all the words. But essentially, to summarize, they are saying that non-coplanar treatment give us a more significant dosimetric advantage, both in terms of OAR sparing and in terms of improved conformality, improved heterogeneity. So this is true for breast, for lung SGRT, for medium sign-on lymphoma. And then overall, there has been a clear tendency towards better plan quality for non-coplanar treatments. So our MD resident, Stephen, is actually working on a systematic literature review for this. So if you guys are interested, keep an eye out. So on the other side, why don't we see more non-coplanar treatments in the clinic? So there are four main sticking points. The first is with the increased complexity in treatments, it comes with increased treatment time. And that corresponds to potentially increased intrafractional patient motion. And then the other thing that people are worried about is with so many moving parts, there will be potentially a decrease in delivery accuracy. And then last, but probably one of the more important sticking point, is that people are worried about patient safety and the potential collision risk. So in order to mitigate the last point, traditionally, most institutions will have some sort of manual angle check process where we will have our two lovely therapists who will be giving a talk a little bit later. Here, performing an angle check with patient's treatment device. So at our institution, we use a sort of a body frame. So this is with a body frame and then the vac lock bag. And then they will have this list of beam angle, beam parameters given by the planner. So they'll go through all of it to see if all of them pass the collision check. And if it doesn't, they'll give some sort of suggestion on how to modify that beam. So typically, at our institution, when this was done, it takes about 15 minutes machine plus therapist involved time per case. And the average turnaround time for this procedure from when the planner submit a request to when the request is done is 6.2 clinical hours. And as you can see from this graph, for certain cases, it could goes on for several days, especially when it involves back and forth between the planner and the therapist on what angles are usable. So to mitigate that, we acquired two MapRT units, UT Southwestern, one for each CT, because we have two CT vaults. So as you can see here, the hardware component of MapRT consists of true horizon cameras pointing diagonally at your CT board. And many of you have already seen some parts of this. The principle of MapRT is pretty simple. Essentially, those two cameras that you saw earlier will acquire whole body patient-specific surface as SIM, and then we combine that with a manipulatable how do I make it? Yep, there you go. And a manipulatable machine model. So you can rotate the machine, the linac around, rotate the couch around, and then it's essentially visualize your available beam space. So to put it in a little more detail, so this is the user interface for MapRT. You have on the left your imported plan parameters. So you have all your beams with your couch and gantry angle. So in the middle, you have the y-axis is the gantry angle, the x-axis is the couch angle. And then you have your yellow dots or lines, that's your beam or your fields or your arc. And then you have the red, which is your collision zone. So, and then on the right, you have your interactive window where you can drag things around to figure out your clearance space. So as any physicist would, when we adopt a new system, we want to test its accuracy. So we did a system QA and validation with physical phantom, where we moved essentially the linac as close as possible to a physical phantom, and then we cross-verified that with MapRT system. And what we found was that MapRT was accurate within 1 degree of couch or linac rotation. And then we also compared, for 60 cases, we'll historically compared the physical angle check accuracy versus the collision predicted by the MapRT. And we actually found that MapRT was more accurate than the physical angle check in identifying collision issues, which makes sense because MapRT is a patient-specific surface. A lot of times you know that the patient's elbow or some part of the patient's anatomy will be sticking out of their treatment device, which cannot be identified in our physical angle check. So we've gone live with the 2 MapRT units, one in last October, the other in this January. So here's a graph of how many physical angle check requests we have in our department. So it's gone from, on average, about 70 to 80, down to about 10 to 20. And as you can see, the big middle peak there is because of the end-of-year insurance rush, because American healthcare system. And then we estimated, on average, there is about 15 clinical hours saved per month of the machine and the therapist's time because of the introduction of these 2 systems. So now that we've established that MapRT is able to help improve our planning workflow efficiency, we want to see if it can do more, whether we can explore its capability to give us essentially better plans. So we test this out with one of the simpler treatment type, long SGRT. In this example, we have a 74-year-old female with a small lesion very posterior, and she was treated with 60 gray in 5 fractions. So now when she was treated, MapRT wasn't actually in clinical use. So what ended up happening was we put the isocenter convention for SGRT treatment at the center of the lesion. And when we put her on the couch, we realized that her elbow is actually very high, that it would cause a collision with the machine based on this sort of reproduction of that scenario in MapRT. And then we ended up having to drop her by 7 centimeters and then putting the ISO at the center of the lung instead of at the center of the lesion, which is not ideal dosimetrically speaking. And then we did the standard 2 partial arc, like shown in the image below. So if we were to replan this patient for non-coplanar treatment, what we would like is essentially to utilize the 2 non-coplanar beams capability to spread out entrance and exit dose, right? So if you look at the top left, this is how we arranged it. So we have 2 couch rotation, one at, I believe, 20 degrees, the other at 350. And then we use MapRT to figure out what's the maximum arc angle that we can use, as indicated here by the 2 yellow line in that collision map. And then the eventual beam arrangement ended up looking at the bottom left. So in comparing those two plans, what immediately jumped out for me was how much more compact the lilac color isodose line is, which is the 25% Rx, in this case, is 15 gray. And then if you look at the dose metrics, the non-coplanar plan was able to achieve a better the paddock conformity index, meaning the plan is more conformal, and it was also achieving almost halving the 25% isodose line. And we were able to achieve this better, more compact plan quality with only 2/3 of the MU. So we did this for, just to see if it's a fluke, we did this for 20 long SGRT patients, and we found that the non-coplanar plans are in general more conformal based on the increase in paddock conformity index. We found that we were able to significantly lower the V25%. And then when we plot the percent of Rx dose versus distance from PTV, essentially this shows you how dose falls off away from PTV. We noticed that there is a much lower dose spillage over a very large range. Essentially, as you can see here, from about 40% Rx dose to about 10% Rx dose. So essentially, we are making a much more compact plan and preventing dose spillage into the surrounding normal tissue. So now that we've tried out using MapRT for a relatively simple plan, we decided to continue on and see if we can do this for something a little more complex, in this case, stereotactic partial breast irradiation. So the reason why SPBI is more complex is because of the critical sparing of the heart. So breast cancer patients, as we know, have a relatively high survival rate, and they ended up having a longer life expectancy. So it is extra important for us to make sure that there's less negative radiation side effect after their radiation treatment. So there's the Darby paper, famous Darby paper from New England Journal of Medicine, correlating every 1 gray increase in mean heart dose to a lifetime excessive risk of 7.4% of major coronary heart events. A lot of those events will lead to death. So there's a follow-up paper essentially in the lower graph showing that they start observing this effect at as low as 1 gray. And this paper also proposed that potentially there's no threshold dose for such damage to the heart. Which means the clinicians essentially need to be extra cognizant when doing these plans to make sure that we lower the heart dose to as low as possible. So we decided to test out MapRT for this case, and we have 2 example cases for the breast. So in this first case, we have a 64-year-old female, large left breast CTV, very, very medial, almost on top of the heart, and it is partially coplanar with the heart. So this patient was treated SPBI 30 gray in 5 fractions. So this is how you will go about doing a traditional coplanar plan with MapRT. So essentially, for the arc arrangement, you try to avoid the contralateral breast as much as possible, and then maximize the available arc angles. And then you check clearance with MapRT in the lower right. In this case, we're very far from collision. Everything looks good. And then you put in the optimizer, fingers crossed, hoping that you can lower the heart dose as much as possible. But we want to leverage MapRT for non-coplanar planning. In this case, our theory is if we can just steer the arc away from the heart based on where the lesion is. In this case, we're tilting both beams, one at couch 345, the other at couch 320. We want to see how much that will help us. So here's the results. And the thing that really stand out for me is how much we're able to push the low dose spread essentially completely out of the contralateral lung. And if you look at the darker purple, which is the 9-gray isodose line, it was very much in the heart, and we were able to get it almost completely out of the heart in the non-coplanar plan. And if you look at the sagittal view, we're essentially, it might be a little bit difficult to see here, but we're essentially steering the dose superiorly to steer it away from the heart. And this is reflected in our dose metrics we ended up with. So we are able to reduce the heart mean dose by 0.6 gray, which doesn't sound like that much, but if you remember what we talked about before, this correlates to about 4% of the excessive lifetime risk of coronary heart events. And we are also able to reduce a lot of volumetric dose for the heart. So in the second case, we have a 59-year-old female, relatively young, and then a large CTV left breast, very close to the heart, and it is, in this case, almost completely coplanar with the heart. So our slightly steering the beam away approach might not work as well. So we decided to do something a little more drastic, adding what's called a vertex field. So in this case, we are rotating the patient 270 degree, essentially. We're making them completely perpendicular with the original axis. So essentially, you have a patient like this, and then you have your gantry, and they'll just rotate like this for a little bit without, knocking into, there you go. And then in the second case, look at this. This is a beam's eye view. Then you can see, using this arrangement, that we are actually completely avoiding the heart, so you can dump as much dose as you need into the target. So this is what the eventual beam arrangement we ended up with. So you have your couch at 0, and then you'll have your couch at 270 degree. So looking at the results, the low dose difference is not as extensive, but if you pay attention to the dark purple 9-gray isodose line again, you're able to see we push that completely out of the heart again, and we reduce the heart mean dose by 0.6 gray, as well as the left anterior descending artery, which has also been associated with coronary heart events. And if you look at the coronal view, which is interesting, because you'll see that the 1.5 gray was pushed completely out of the heart. So, again, just to make sure it's not a fluke, we did this for 18 SPBI patients, and then we were able to ensure similar plan quality. So based on the lower left, that's all our plan quality indices. And then we were able to lower both the heart and the LAD doses significantly. So at this point, I would like to go back to our original outline, and we will revisit the point where we talked about why don't people use non-coplanar treatments. So we had 4 points that we were worried about. The first of all is the treatment time. So for this point, we actually went back and did a test run on the breast treatment that we just talked about, where you have to rotate a couch to 270 degree. And we found that from beam on to treatment finish, the coplanar beam took 2 minutes, and the non-coplanar took 2 minutes and 30 seconds. And that 30 seconds is including me basically having to go inside of the vault to rotate a couch, because that's our clinical policy to ensure patient safety. And I don't know about you, I would say 30 more seconds of treatment in exchange of 4% of lifetime coronary event risk, I will take it. And then correlating to that, if you're still worried about additional intrafractional patient motion in that additional 30 seconds, we've been having great success with SGRT-based motion monitoring. At the moment, we actually use SGRT to gate another type of our treatment, SBRT larynx, where we always use large couch rotation angles. And then for delivery accuracy, modern Linacs and the couch are actually very precisely manufactured, and then we make sure the walkout due to couch rotation is all sub-millimeter. And then last but not least, I hope that I just made a convincing case that SGRT-based virtual clearance mapping is able to help us with the patient safety and collision risk issue. With that basically concludes my talk. We don't have to basically worked well. Thank you very much.